I'm Dr. Vel Arvind, and on behalf of Peculiar Case and Renal Transplant, I take great pride in inviting all for the 32nd edition of this going last 3 years very continuously with a lot of impact, and the contents are very good. That's appreciated by many people, which was in fact a great impetus going this program in a big way. Today we have two speakers, a lot of similarities in the two cases, and a lot of similarities. One is both are from the sister concern of Apollo Hospital. One is in Chennai and is in Bangalore. And both cases are pediatric cases, less than 10 years. And both cases have received an organ from deceased donor. And the complications almost are similar to each other. Going to be entertaining journey, and as well as a lot of learning points I think both speakers is going to present to us today. And this both have some kind of urological issues as well as the technical, some divine intervention where they're to save the patient from pulling out from the difficult situation. It's a real thing. Ultimately, stories ended in a success. Both childs are doing well right now. So, which is Matado, I just jump on to, call the speakers to, present their. Okay, before that, I just want to introduce two panelists. And today I have a great honor, and it gives me a lot of, pleasure to have Dr. Chako sir. I invited him to be a panelist for this program. He promptly accepted. Sir, ever since you came into this Peculiar Cases platform, your comments were really nice and very sharp, and you threw a lot of wisdom in each queries raised against some uncertain points. So I honestly believe, I don't think there is a retirement in life. There is no retirement in life. I think I honestly believe the broad roadway begins after the retirement, and in such a way that in many aspects you are charming, adorable, and you are you are simply your knowledge simply matching with the brilliance of young brains, and you catch things very quickly and respond very nicely. I haven't worked with you for a thing, but I see from distance how you involved at this age, and we really admire you and love you, sir, for the all the enthusiasm you show, and your dancers are very impeccable and gives a lot of wisdom in that. You are just from distance, you are guiding, you're steering our mind, so that we not deviate from such of a medical ethics. Always you talk about ethics in your answers. So in my mind, there is retirement is open document. It is lies on in our hands to make it rework or restructure it. You are real illustration. So thank you, sir, for being here with us today. And it's a really honor for us to to have you here on this platform. And second, very contrast. This is the first time we have roped in a urologist to this program, and because this both one at least Saravanan case requires urologist intervention to give some kind of insight into the case discussion. I welcome Dr. Muruganandam. I said, I got information about Raj. I think it's Raj's batchmate, and he's a director of urology institute at Gleneagles City, Health City, Chennai, and he's leading a transplant surgeon, and it's also a part of robotic surgery. I think from Raj's words, he has evolved into a very highly talented transplant surgeon to rely upon. So thank you, Dr. Muruganandam, for being here with us today. So much ado, I just invite speaker to. Before that, I just would like to ask Dr. Chako sir to give just few words about some kind of encouragement, whether we are on the right track in this WhatsApp group forum. Sir, please, sir, and then we can start having our presentation from our speakers.
Yeah, thank you, Vel, for that introduction. And I remember very clearly you're approaching me at breakfast at one of the meetings and saying that I should be part of this group. And I told you that I've actually stopped actively doing transplants, but I think it's still a pleasure to be part of this group. Actually, the level of academic discussions is extremely high. But as you rightly pointed out, I sometimes get concerned about whether we are really skirting at the edges on some of the donors that are being taken up. And I I don't feel bad about commenting on that. I hope it is taken in the right spirit.
Yes, sir.
So, and thank you for having me this evening. And I'm really looking forward to both the presentations. So I think we can start with one by Dr. Arun Kumar.
Yes, sir.
Yeah.
Arun, you can share. Let's start.
So thanks a lot, sir. Hope it's visible, sir.
Yes.
Yeah,
yes.
very much. Your voice is very clear. Please go ahead.
Yes, sir. So this discussion starts with why me. So this is Arthur Ashe. 1 million Americans have heart attacks every year, and I was one. So he had an heart attack in 1980, and then when he wanted to undergo a bypass surgery, he was transfused blood. So he was diagnosed HIV positive 5 years later, and then he used to get millions of mails, letters, and words telling that America has been cheated and God has been unkind to you in all forums. Why? Because you were such a soldier and were fighting for the nation and getting accolades everywhere. But God has cheated you and given you something that you never deserved. So at that time, HIV was not regularly being tested for before transfusion. So he one day decided to reply to them. 5 lakh people start playing tennis, out of which 50,000 continue. 500 reach international level. 50 reach a Grand Slam or get a rank. 2 reach semi-final. And when I've been victor and I've held that cup, I've never asked why me. But when God has given me HIV, why should I ask God why me? So it all starts with why me. This is a case of baby Lithi. She's 8-year-old girl from Gudiyatham. She's A positive blood group with no past allergies. Her BMI is 14.2 kgs. So I cannot exactly tell it is a history, but it is a story and history. She's the first child of a non-consanguineous marriage. She's born at term, and she had normal milestones till the age of 4 years. After 4 years, she developed ascites, and she was evaluated at CMC Vellore and was told to follow up in OPD basis. Further, she had worsening of her ascites at the age of 7, and this time she was taken to Rela Institute in Chennai. She was evaluated thoroughly, and she was found to have congenital hepatic fibrosis with ARPKD, autosomal recessive polycystic kidney disease. Her creatinine at that time was 1.8 milligram per DL, and she had a proteinuria which was subnephrotic, around 1.6 gram per day. So she was told to do
You're not audible, Arun.
Arun?
Sir, not audible, sir?
Yeah, just for a few seconds.
Back, yeah.
Okay, please go ahead.
Yes, sir. So this is her mother. Her mother is a doctor and father is an IT professional. This is one of the pictures which was taken in Chennai. And in Chennai, she was diagnosed with SPP. And at that time, she was thoroughly evaluated and multiple cultures were done. And they picked up multiple drug-resistant organisms, both in urine and also in ascitic fluid. She was diagnosed with UTI with Klebsiella multiple occasions.
Arun, again, your voice is getting interrupted. Please check. Arun?
Hello, sir. Can you hear, sir?
Yeah. For a short while, we lost your contact, but now it's okay.
Yes, sir. Yes, sir.
Sir, could you please turn off your video, sir? I think your bandwidth is low.
Let him go ahead.
I
think he's connected. Karthik, just leave him, and because the time is very important.
Okay, sir.
Yes. So candidemia in blood, and she was treated with antifungals, and she developed first episode of seizures when she was admitted in the institute, and it was attributed to sepsis and dyselectrolytemia, and she was treated for the same. She was started on anti-epileptic drugs, Levipil 500 mg, 250 mg BD, and she was also on mechanical ventilator post seizures, and she was on ventilator for 5 days, post which she was extubated. She was also initiated on dialysis at the same time because the creatinine went up to 4, and 5 sessions of hemodialysis was done. And then she was discharged. She was there in the hospital for almost 2 months. And because she had persistent ascites, pigtail was inserted for draining of the ascitic fluid. And she was advised that every day or alternate day, she had with albumin infusion given once in a week. She was given around, and her baseline weight was around 12 kg. But
Arun, can you check whether it's getting interrupted again and again?
my internet is completely normal, sir.
I don't know whether it is me or everyone else with having same
Every-
problem.
We are
Yeah,
not
okay.
able to interruption is there.
Voice are getting,
Sir, now, sir?
yeah. Please go ahead. No issues, please. No, 1 or 2 minutes is acceptable. Please do go slowly, and you have to serve the purpose of presenting good. Okay.
Yes, sir. Her
Please go ahead.
baseline weight, and then she was having active UTI infection when she was
Arun,
discharged.
you have to come to the full screen, Arun. Arun, you have to come to full screen. Now it is gone.
Full screen, sir. It's full screen.
Yeah, it is now. It is in a slide bars, and you are in the only slide bars we can.
So now, sir?
No, Arun. Yeah, okay, fine. Please go ahead.
Hello?
Yeah, now it's all right.
Yes,
Yeah.
Arun. Yes, Arun. Again,
Yes.
it's gone back to the side. Yeah, okay.
Now can you see, sir?
Yes. Yeah, yes. Perfect. Arun?
When slides are coming, voice is going off, and voice is coming, slides are going off.
Arun?
Sir, hello, sir.
The thing is, no, we are not having, your voice is not synced with the images which is been displayed on the screen. Probably you can change the internet source, or you can make it a hotspot, something from your mobile.
Yes, sir.
Are you working on any Wi-Fi?
Yeah, I'm using Wi-Fi, sir. Sir, can you hear now, sir? Is it now clear? I've changed
Yeah.
my Wi-Fi also.
Yeah,
Yeah.
okay then. Okay, fine. Arun. No issues. Please make to the full screen and go ahead.
Now you can see, sir.
Yeah, fine.
Yeah.
Yes, fine, Arun. Fine.
Yes, sir. Sir, she was registered in Tamil Nadu for cadaver donor for simultaneous liver and kidney transplant. And subsequently, her mother, father, grandmother, and grandfather, maternal grandmother and grandfather were evaluated for live donation. However, there was ABO incompatibility, and also they were all cross-match positive. So paternal grandfather was selected as his cross-match was negative. So he was told that he can donate, and she was followed up. She came to Apollo Hospital through one of her known persons because she was in the hospital for 2 to 3 months and they wanted to have a second opinion. So she was sick and was evaluated thoroughly by the transplant team. At that time, she had SBP and she was continued on the ascitic fluid drainage as per whatever it was advised in Chennai. She was admitted for 3 days and was advised for a cadaver donor registration at our hospital. Family was, however, wanted us to push and get the grandfather ready for the live transplantation. But to be very truthful, we had felt that she will not survive. And if we do a transplant, we may lose her because of infection. So we were a little bit hesitant to go ahead and do a live transplant. So we motivated the family and told them that cadaver donation would be better. So she was registered for cadaver after 3 days of workup. And on 14th day, they were about to leave to Chennai, and we got a O positive donor, a 14-year-old donor, or pediatric donor. And she was the only pediatric donor available at that time in whole of Karnataka for a simultaneous liver kidney transplant. Here, the cadaver donor was O positive and she was A positive. So because we have an in-house donor and she is the only pediatric donor available in Karnataka, so we could use this O positive donor for her. So we had to think a way because she was not prepared for the transplant. So I had gone to Delhi once and I had met this people from Aquadex. So they told me that we can use this aquapheresis for removing a large quantity of fluid. So she was around 30 kgs when we wanted to do the transplant. So anesthesia evaluation was done, and it was told that we have to do either CRRT or do a sled. But her creatinine was not very high for us to go ahead and do all these procedures. And her BP was mere 80 by 60, 80 by 40, 80 by 50. So we couldn't go ahead and do a CRRT when we didn't know that whether we are going to get an organ or not. So we were all perplexed. And so I got this idea that we can ask the aquapheresis people to do a aquapheresis with Aquadex. And prior to doing a transplant, we plan to remove around 5 to 6 liters of water over a 10 hour span. So we did aquapheresis for her for removing 5 liters of water in over 10 hours. And she was allotted the organ from a O positive donor as it was an in-house cadaver. So initially we planned a single lobe transplant as she was very small. So we thought the same liver could be cut into 2 halves and 1 half given to her and the other half can be transplanted into an adult donor. And because the donor was also, he was also well built and he was very tall. And we thought that this organ would not be sufficient for her alone. So we could use it for 2 people. So the problem we had at our hands was she had undergone multiple transfusions. Her cross match was positive, and her creatinine at presentation when we got the organ was around 2.2, and her urine output was 50 ml per day. She was very, very sick, and not needing inotropes was the only thing that was not there. Other than that, she was malnourished. However, she was vaccinated for hepatitis B and not vaccinated for PCV at that time. At examination before the transplant, she had no edema legs, but gross ascites. Pallor was plus, and she had an indwelling pigtail catheter. No icterus cyanosis clubbing thyromegaly or any infectious focus. Her BP was 140/90. Pulse rate was normal. And urology evaluation was done in view of ARPKD. So we had a normal iliac vessel Doppler and USG, but we had planned for a native nephrectomy because she had ARPKD and multiple cysts. And she had a UTI with E. coli, Klebsiella. She also had Candida. So all these things were put together. We thought that we'll need to do a on-table nephrectomy. Initially, we thought we'll do an on-table nephrectomy. But however, our urologist told that we will be able to do a left iliac fossa transplant because there is space there. And they had to use the right iliac fossa and the right hypochondrium for the liver transplant. So it was planned that native nephrectomy would be done. But however, in the end, we didn't do a native nephrectomy, and left iliac fossa transplant was planned. So the liver team was of the suggestion that we'll do a partial liver transplant, and possibility of the duct mismatch was also explained to the family and relatives. But however, when we did a CT scan of the baby, we found that her liver was absolutely fitting her. So we diagnosed her as congenital hepatic fibrosis with ARPKD and with severe malnutrition. So the donor was a 14-year-old boy who came from Tumkur, and the donation was done post-brain death. Immunology, we could only do a CDC cross match, which was negative, and we had to leave everything to the Almighty because she was multiply transfused. Her cross matches were positive in the past, but because there was a liver, we thought that we will get through the transplant. And here we had another round of discussion where we had to discuss whether we have to give induction or no induction. We had a discussion with the liver team. They were of the opinion that if we give any induction, either ATG or basiliximab, we will be putting her into a jeopardy of giving an infection. So after a lot of discussion, we decided that we'll not give any induction. We'll just do it with steroids. So and we also discussed that we'll keep the TAC, MMF, and steroids to as low as possible. So without induction, only with steroid 500 mg, we did the transplant. So she felt she was into a very high risk category because she was a SLKT recipient with multiple infections. She had a hospital stay of more than 6 months with multiple blood transfusions and cross-match being positive. So challenges we had is one is antibody-mediated rejection and infections, which could be anything, which we have never seen in our life, also could be possible in her. So we did the transplant. Transplant went on well till 7 days of post-transplant. Everything was hunky-dory and we were very happy. But on 7th day, she had fever. And then we evaluated her and we found that she had sepsis and it was SBP because she had a gross ascites and it was drained while doing the surgery. So we actually punctured and all the fluid was removed. So the surgeon told that it is better to re-explore. So we did antibiotics for 7 days, but her fever never came down. So we planned for a re-exploration, and a CT was done, and it showed there was some collection in the hilum of the liver. So they thought it is probably a clot, and there was some amount of clot, and there was an infectious focus, which was a yellowish thing, which was deposited there, probably a pus. So from the hilum of the liver, it was aspirated on POD 15, and we were fine. The next day, she did not have any fever, but we were all in for a shock. At 2 a.m. on POD 7, she had status epilepticus, continuous seizures, which did not come down for any anti-epileptic drugs, multiple loading doses, and then we had to give her thiopentone sodium and give a GA, and she was kept like that for the next 48 hours. So 48 hours, we did a EEG. EEG did not show any activity anywhere, and so we thought it was probably a sepsis-induced seizure, which was a precedence that she had before. She was on ventilator for almost 8 days, but on 4th day, we discussed with the family and told that because she's a pediatric girl, we didn't want to put her through long duration of ventilator alone with the tube, and we were worried about infection, VAP. So we told the family, and we did a tracheostomy on day 4, and we continued on ventilator for the next 8 days. So everything was fine from day 17 to next 8 days, and then she was fine and recovering very well. But then later, slowly her bilirubins started going up from 0.4 to 3.6, and her liver enzymes also started increasing from 14 to 460. So initially we thought it was rejection because we had come down so much on immunosuppression. She was only on MMF 250 mg. So tacrolimus was stopped. Steroids were given single dose, and we didn't give for 3-4 days of steroids. And only on MMF we kept her on 250, and then later we stopped MMF and we continued only on steroids. So this biliary stricture was on POD 31, where there was a mismatch between the donor and the recipient bile ducts. So it was stented with a plastic stent on POD 31. Finally, we weaned off her from the ventilator and discharged her on POD 38. So how did we come into this Aquadex? So this aquapheresis was a technology which was used in US for predominantly cardiac patients. And it was initially done in 2010-2014 for a pediatric hemodynamically unstable patient. And here there was a multi-organ dysfunction. So the whole of the study, in this case report, they reported that they did ultrafiltration for a pediatric cardiac intensivist patient who was an 11-year-old 25 kg male with a complex single ventricle anatomy, who underwent a surgery, ventricle half repair, and experienced multi-organ dysfunction syndrome, including an acute kidney injury. So in early post-operative period, secondary to low cardiac output, and he also had tachyarrhythmias, he developed multi-organ dysfunction. So there, because of acute kidney injury, they used ultrafiltration using Aquadex for fluid overload and to achieve a negative balance. So over a period of 2-3 days, they did aquaresis, and they finally could achieve the negative fluid balance using only ultrafiltration therapy, which was feasible, and it was in a hemodynamically unstable patient where they could attain hemodynamic stability and also help the patient recover. So they concluded that it was the first report of ultrafiltration therapy with Aquadex system in a pediatric cardiac intensive care patient, where they successfully achieved a net negative fluid balance with a very complex and without any compromising of hemodynamic stability or causing any significant electrolyte imbalance in the setting of arrhythmia with subsequent improvement of overall clinical status. So they also suggested further studies are required to assess the utility of this therapy of fluid overload status and also CIRS response in other pediatric patients. So this was the whole story, but where was the divine intervention? What happened in this case? First of all, she coming to us from Chennai was a divine intervention, because one of her known person asked her to come from one of the premier institutes like Rela to Apollo for transplant. And after registration, within 2 weeks, she got a pediatric donor who was 14-year-old. There is a story for this pediatric donor also. He was a second son of father and mother. Elder son was 35-year-old, and he was obtained after a lot of puja and this thing. So the family, he and his brother were going in a bike. So they both hit a stone. He fell down and he walked into his house without any problem. After few hours, he developed headache, for which he was taken to a local hospital. There, they evaluated and told that nothing in the brain, you can go home. So he came home and then became unconscious. So they brought him to another hospital. So there they did a CT and found out that there was a SDH and it was there was a compression and there was a herniation. So they decided to travel 70 kilometers with 50-60 hospitals on the way, and they came to Apollo. They didn't know anyone in Apollo when they came and arrived. So at the same time, our urologist was in Turkey attending a conference. So we called him and told that we have got a cadaver for this baby. So he went and searched for a ticket. There was no ticket available directly from Turkey to Bangalore. So he told that he'll not be able to come. So we had to talk to another transplant surgeon for us to do the kidney. With so much complex things of doing a nephrectomy on table was decided prior only. But for our liking, there was a new flight which was put from Turkey to Muscat, and from Muscat to Bangalore, there were a lot of flights which were available. So he took a 12-hour journey and reached at 9 a.m. The surgery was planned at 10 a.m. So he reached Bangalore at 9 a.m. with a special flight. And this Aquadex machine also, there is a story. I called this company Aquadex at night, telling them that we have a cadaver at 12 a.m. and told them I need an Aquadex machine. But they told there was a cardiac patient for whom Aquadex is being used. And so they'll not be able to provide this Aquadex machine to me. And then I requested them, but they couldn't provide the machine because it was on use. But later on, after 1 hour, they called me and told few months back, there was a machine which was brought to Chennai, and the machine is lying down in Chennai, and there is no one using the machine. So we can shift it if we wish to shift. So I was very interested to shift that machine. So we shifted the machine, and the machine reached through flight at 2 a.m. to Bangalore. And then the organ being totally mismatched, because initially we felt that the organ was very big, the liver was very big, and it wouldn't fit this girl baby. But because there was gross ascites, there was huge space, and I will show you the picture how the liver fitted into this baby. And she had good recovery, and 7th day she developed infection, SBP. Then later we thought it's just an infection, we'll get over it. But when she had GTCS another night at 2 a.m., we had given up all hopes because she had aspirated, and we intubated her, and we thought she'll not make it at all. But father was so sure that he told, sir, whatever happens, she'll recover. This has happened to her before, and she will recover. Whatever it is, God is there, and she will come back. And he told us the story that happened in Chennai also, that how she recovered from all this. One more fear that we had is we had not given any induction. She was transfused multiple times, and we had brought down immunosuppression to such an extent that we were giving her only Visalone 10 mg. But still, the graft survival was a question mark, but she survived. So this was a case where we did Aquadex to remove around 5 liters of fluid without hypotension. And first case in India where we did it for a liver kidney transplant in such a critical patients, preparing her for the OT. So this is the picture of the liver exactly fitting into the abdomen. The whole liver was kept for her. So initially we thought we'll put one lobe, but we got the full liver into her, and we put the kidney on the left side. So just briefly, I'll go through how and what mechanisms is used for aquapheresis. See, Aquadex is a smart flow system which used a simplified approach to ultrafiltration for removal of salt and water in patients with hypervolemia or fluid overload. So compared to renal replacement devices used for ultrafiltration, Aquadex is a smart flow system, and it is small and portable. It is easy to use and start, and it does not have any cumbersome circuits and procedures. So any physician who knows extracorporeal therapy can give advice for Aquadex. and there is a gradual reduction happens of fluid removal without significant impact on the blood pressure, heart rate, or balance of electrolytes, sodium, potassium, magnesium, and other electrolytes in the body. Up to 500 ml per hour of excess fluid can be removed with no clinically significant impact on any electrolyte balance. So it has three parts. One is a console, one is a peripheral catheter, third is the Aquadex blood set. So the console has a central unit. It controls the entire system, including the blood flow rate and amount of fluid to be removed. Whereas the catheter is a small catheter where we draw blood and give it back to the patient once the aquapheresis is done. The blood circuit set is very disposable set, and it contains filters that separate excess fluid from the blood cells and other components. And the filtered blood is again returned back to body. Here, it does not remove the protein. It concentrates the protein on the blood side so that there is no need of giving any replacement in the form of albumin or any substances. So it's easy to operate and safe to use. It can be prescribed by any physician trained in extracorporeal therapy. It delivers safe and precise therapy with the ability to adjust the fluid removal rate and also volume to meet each patient's clinical need. Approximately 35 ml of extracorporeal blood is needed of patent blood circuit, and no significant changes in electrolyte balance. And it is easy to set up where you can allow 1:4 nursing for the patient, like as in CRRT where you need 1:1. So new hematocrit and SVO2 features provide clinical insights and may also help in guiding the therapy decisions. So this is a new addition to aquaresis. So history, so it was pioneered in 1990, where the medical components like CHF solutions recognize the need for safer and more efficacious way of removing and managing fluid overload beyond traditional methods like dialysis. So early prototypes of Aquadex system emerged, focusing on removing excess fluid without affecting electrolytes or blood cells. So if FDA approval was obtained in 2000s, in 2002, the Aquadex system received FDA approval for treating congestive heart failure and marking a significant milestone. So the clinical studies demonstrated its effectiveness in relieving symptoms and also improving quality of life for heart failure patients predominantly. The technology has continued to evolve with advancements in systems and design and also control features, addition of SVO2 and also hematocrit. So expanding the application, in 2010 to present, Aquadex gained wider recognition as a versatile tool for managing fluid overload in various conditions, including liver disease, kidney problems, and even certain transplant procedures. So the system's portability and ease of use contributed to its adoption in critical care settings, and ongoing research continues to explore new applications and refining the technology for optimal patient outcomes. So the process of aquapheresis is, one is preparation, where we do a medical evaluation. Second is catheter insertion, where we insert a catheter which is required for removing and entry of the blood. So fluid removal is done by 4 methods. One is blood circulation using the inserted catheter. The blood is generally drawn from your body and circulated through the aquapheresis system. So second is filtration. The system employs specialized filters that selectively removes excessive fluid while retaining essential blood components like proteins and also their blood cells. Fluid separation happens. The filtered blood, now with reduced fluid content, is separated from the extract fluid waste and returning the filtered blood. The filtered blood enriched with vital components includes albumin, is returned then to your body through the same catheter. Generally, what we do when we do dialysis in such patients with so much fluid overload, we have to give albumin. Here, the concentration of the albumin increases on the blood side. So there is no need of giving albumin in patients when you are using aquaresis. See, that was one of the biggest points for us using aquaresis in this case. So throughout the process, the healthcare professional closely monitors vitals and also fluid balance and blood chemistries. The rate of fluid removal is precisely controlled by the aquapheresis system to ensure safety and effectiveness. However, there is no hypotension or any abnormality in the patient, which we saw in this patient when we did the procedure and removed 5 liters of the fluid. The procedure typically lasts for several hours depending upon the amount of fluid needed to be removed. We can continue it like doing a CRRT. We can use it for 16 hours, 18 hours, and then recharge the system and reuse again. So post-procedure, patient is monitored for a short period of time and can be discharged or can be performed in OPD clinics and at home also. So it is easy to transport machine and very handy, and it is very effective in fluid removal and for reaching our set targets. So benefits of aquapheresis is isotonic fluid removal, the same concentration in ultrafiltrate and cells within the body, low extracorporeal volume. The volume required is around 35 ml, and small priming volume is required. Console has a battery backup of 30 minutes and enables patient ambulation also. Nursing ratio is 4:1, whereas in CRT it is 1:1. And no replacement fluid is required as like in CRRT, where you have to give a replacement fluid. So ultrafiltration using the Aquadex smart flow system offers a safe and precise approach to treating fluid overload and has been shown to have no significant changes in electrolytes, and there is no activation of RAS. So it stabilizes or improves cardiac hemodynamics also. It restores diuretic effectiveness in patients and also allows for improved response to diuretic agents. Once they become diuretic resistance, you can use Aquadex and then again go back to using diuretics. So totally 60,000 patients have been treated with this fluid overload condition, and very few transplant patients in this. It removes about 500 ml per hour, that is 12 liters per day of excess fluid with no clinically significant impact on electrolyte balance. Easy to set up and monitor, as I've told you. So predominantly, there is 53%. This is a study from American Heart Journal. So where there is a 53% reduction in rehospitalization because of HF at 90 days, 52% reduction in unscheduled hospital visits in heart failure patient at 90 days, and 63% reduction in rehospitalization. Safely, it reduces the length of stay and readmissions. So the different areas of therapy, predominantly this was for heart failure patients. It can also be used in CV surgeries, valve replacement surgeries, and also used in sepsis. In pediatrics, in heart disease, cardiac surgery, and also in transplants. So the advantages of aquapheresis compared to loop diuretics. In loop diuretics, there is unpredictable elimination of sodium and water, development of diuretic resistance, risk of hypokalemia, hypomagnesemia, with insufficient symptom relief, and there is still a reaccumulation of fluid in a faster rate, and worsening of heart failure and increased mortality at discharge and increases re-hospitalization rates. Whereas in Aquadex, there is predictable removal of salt and sodium and fluid, restoration of diuretic responsiveness, no change in electrolytes. In predominantly, it is potassium and magnesium, which are normal, and it is an effective decongestant, fewer heart failure events compared to loop diuretics, and improves glomerular filtration rate, and it is efficacious and produces improved outcomes. Price, roughly the cost of the procedure is 1 lakh for 3 days, which includes full taxes. Total cost of the machine is 30 lakhs, which can be availed in rental basis also. So this is mother and father. I have taken permission for displaying the photos, sir. So this is the first picture. This was at Chennai Institute. She was on multiple lines and RT feed. So this was at discharge. So mother and father, she had an RT tube. We didn't want to remove because she was not feeding well. We wanted to maintain her nutrition. So this is POD 48, her birthday. The younger one is her sister. She is also diagnosed with congenital hepatic fibrosis with autosomal recessive polycystic kidney disease. Her creatinine is 1, and she does not have any manifestations as of now. Her genetic test is sent. We are awaiting for the reports. So this was her POD 48, and she and her sister now. This is a recent 4 days back photo. This is 3 months post-transplant, and selfie and self-makeup. This is all done by her. This is her selfie. So our conclusion, this is the first case of simultaneous liver kidney transplant using Aquadex in South Asia, as told by the company, sir. I have no authenticity on this. The company themselves told that they have not done it anywhere else, which the FDA has approved recently for a pediatric patients. And as a team, it was a case which made us all feel the gratification when we discharged this baby after 37 days of hospitalization. So coming to the first slide, why me? In the end, 2 people are asking each other, why me? One is me. Why me? I was chosen to do this transplant. Her mother and father asking why her daughter, that is both daughters, have got this and why they have been chosen for this suffering. So with this transplant, nothing is impossible with divinity and science put together. Transplanted 4 months ago now. She's doing well, and they lived happily ever after. Special thanks to my teacher and mentor and divinity in him, always who guides me when I am in deep trouble, Dr. Satish Balan. He has given a lot of inputs in this patient, and on that day when I called him with seizure, he told Arun, still there is a chance, keep trying. But we both knew that it was a deep trouble, but still somehow, by God's grace, we could discharge her, and she is doing really well. Thanks for this presentation and the organizers for allowing me to present, and sorry for the initial disturbance.
That's okay, Arun. You made it a day for us. It's a very awesome, very nice. So before I hand over to Dr. Chaku sir, the two quick answers, questions from then we can hand over to sir. See, there is a very apt question came from the chat box. What is the difference between SCUF and slow continuous ultrafiltration and this, and whether anticoagulant should be used or not? This is the one. Then we can give it to Chaku sir for further.
Sir, one, in SCUF, what we do is we need a large volume. Second, when we remove fluid, you can only continue it for 4 to 6 hours or like that. But here in this patient, one, we couldn't use an anticoagulant because our PTINRs were deranged. Second, we didn't want to do SCUF because there is no particular pediatric machine for which you can use SCUF. In this case, we wanted to remove large fluid without hypotension. Whereas when you do SCUF, there are possibilities that you will end up inducing a hypotension and hypoxia and things like that. So we didn't want to do it. And this company had given us so much assurance that there wouldn't be a little bit change in the blood pressure also. And it was like that. So we were hesitant doing SCUF because of the hypotension and also the deleterious effects which were there with her just before the transplant. We didn't want any adventure on the previous day. So that is the reason we chose this in terms of SCUF.
We'll quickly run through opinion from suggestion from sir. Saravana, can you unshare for a while so that we can see him? Saravana? Sir, Chaku sir?
Yeah, I think, you've gone to a lot of trouble to get this child out of the woods. And what is the kind of filter that they use? What membrane is it that is, so biocompatible that it doesn't cause hypotension despite removing such large volumes? Do you know what the membrane is?
Sir, exactly. Sir, to be precise, I don't know what the material, but what they say is it is built in. Sir. It's not a filter that you add, but they say they can add also extra filter and do it. Exactly the content I don't know, but what happens is it concentrates all the albumin, protein, everything on one side, and you remove the fluid, and then it is again re-brought into the blood compartment. So what happens is only the fluid is removed, and the concentration is maintained, is what they say. Exactly to the depth, I don't know, sir.
Yeah, but then that's the same thing with isolated ultrafiltration, isn't it? You will only remove fluid and all the other things get concentrated. So there must be something particularly, there has to be something in the membrane which is, a very biocompatible type of membrane, which is, actually there is a similar machine, which I think there's a Swiss-made machine which is available. But that does all kinds of things. It does CRRT, it does this aquaresis, it does CAPD and all kinds of things. They had it on demonstration at one of our meetings recently. And the cost is about the same, 30 lakhs they were talking about.
So here we didn't want to use CRRT because we were not having any acidosis, sir, nor we had any other thing. We only wanted to remove fluid because she was overloaded. So that was the only idea.
Another medical question: have you've done a bilateral nephrectomy, single nephrectomy, any nephrectomy done?
No, sir. No, sir. No nephrectomy, sir. We kept the kidney there, and once they opened, the urologist told me that the cysts are not looking infected. Maybe it was the SBP only, which was the infection, and urine culture, you don't know, multiple times it came positive. So surgeon told no need of removing the kidneys as of now, because the size of the kidneys are also not very big, so that there's no space. So he told we'll continue with this and see how it goes, sir. So we didn't do the nephrectomy at all. So the native kidneys are still there in now.
Obviously,
you didn't do nephrectomy on this.
But any role of tolvaptan in this to prevent the native cysts from getting larger?
Sir, tolvaptan usage previously was not to be done because she had a liver disease. Now I think we can think of doing it, sir, probably, but I don't know how effective it would be in ARPKD.
Yeah, ARPKD, there is not much data actually. There are 2 studies which I think the reports should be coming out fairly soon on tolvaptan in autosomal recessive. Certainly, it is shown to be useful in autosomal dominant polycystic kidney disease, tolvaptan. So there may be a role. I think you need to keep a watch out on literature and see whether that needs to be added or not. There any other questions or queries from the audience?
Nothing, sir. This this must evoke a lot of questions, sir, but we don't have time to do it. But amazing presentation, and you've given a lot of your journey was so entertaining and interesting, Arun. And you
Yes,
have a lot of persistence, and you know you travel with the patient family so well.
yes, sir.
And I think this kind of trust existed, and divine intervention all worked on your favor.
Yes, sir. Thank you,
It's really we must congratulate you for such a great work you have done on this patient.
Thank you, sir.
Okay, thanks, Arun. Saruna, can you share and proceed? Saruna, are you there?
Yes.
Yeah, please.
Good, I think.
Yeah, am I audible, sir, now?
Yeah.
Yes, Saruna. Yes, Saruna, please go ahead.
Sure.
Make it a full screen and no proceed.
Yeah, now?
Yeah, it's fine, Saruna.
Yeah. And it's almost like, no, we're going to finish this session, like, because it's almost near 9. I thank organizers and Chaco, sir, like, no, my group, CMC Vellore. And like, no, we generally, like, we have such a turbulent close in liver and kidney transplantation, in liver transplantation. We generally don't see such a turbulent course in a pure renal transplantation. But like, no, we had a patient 2 months before, like, means almost like, no, sleepless night for me and for the entire team, like, they would who took care of this patient actually. So this, I'm just like, no, this incidentally, like, no, this is also a pediatric patient. He was 6 years old. Basically, he's having a vactal anomaly. Vactal means he's having all of this skeletal anomaly. He's having a alien hands, cleft lip, cleft palate, and he's having a reflex nephropathy and it's dysplastic kidneys. And he was on CAPD for 4 months before the transplantation. Actually, he got a cadaver call on November night, and he got the kidney from CMC Vellore. One kidney has gone to, like, no, it is in-house kidney from CMC Vellore. The other kidney has gone to Vellore, and it was exchanged to a 21 years old male recipient. That other kidney came to our hospital. So he underwent renal transplantation on 30th November 2023, is exactly 2 months before. And intraoperatively, like, no, because the surgeon wanted to place the kidney inside the abdomen. So when he opened the abdomen, he found, like, means in the peritoneum, what he found, like, no, he found that that bilateral native kidney was not so healthy, and he felt like, no, there was a pungent smell and was there, and like, no, he just nicked the pelvis of one of the dysplastic kidney, and he found a pyuria. So he did a native nephrectomy at the time of cadaver transplantation. Hence, ischemia time was prolonged. And there was, like, no, you can see that, like, there was a complete oozing in the abdominal thing, kind of like a complete oozing, and he couldn't be able to stop that one. So he just placed a digestant, he just closed the skin, and he didn't close the entire abdomen. Actually, he came out of the theater. So the child, like, no, received in the pediatric ICU with ATG on flow. On child, when came to the ICU, the child had a bloody drains, and BP was in the lower side with hypotension and severe acidosis. So the child was managed conservatively with IV fluids, IV bicarbonate corrections, and we had to give a lot of blood products because there was a continuous bloody oozing um, from the drain. So this was, like, no, not so expected, very common in pediatric transplantation. So, like, no, somehow, like, no, we managed that night. I stayed in ICU itself that night, and we were continuously giving IV fluids and blood products and FOPs and other thing, like, no. And by the next day, my child BP stabilized. And but there was a persistent oozing from the drain. Initially, it was bloody, and the next day it changed to a serosanguinous one, but the volume was pretty high actually. So on the second day, we sent the drain sample. So the same drain sample for the creatinine, the same time serum creatinine was also sent. It was almost equal. So we thought like, no, it could be a serous leakage only from the peritoneum, because the native kidney was like, no, was removed, and there was lot of like, no, peritoneal handling was there. So we thought like there was a leak from the peritoneum. And so we monitored like, no, the drain and vitals and everything, and we steroid and tacrolimus MMS were administered as per the routine protocol. But I didn't give further ATG because like, no, he had an hypotension when he was coming to an ward from theater. So I didn't think of giving another ATG because I had a doubt like, no, whether the child develops again reaction or hypotension, like, no, it would be very risky. So I just uh, continued only steroid, tacrolimus and MMF. And gradually, like, no, that transplanted kidney started functioning and the child started making urine output. He didn't require any dialysis. So we just did a routine daily ultrasound monitoring of the collection, and anything was there because there was a continuous leaking of the drainage was there. So it revealed a big collection around the perinephric region. And the surgical team also saw the patient and said it's predominantly a serous collection. Just wait and watch. So till post-operative day 6, there was no any complications, and child was planned to shift out to ward, and the child reached a native creatinine of 0.6 milligram. And meanwhile, like, no, we sent that native kidney because it was pungent in smell, and there was a urea also was noted. So that urine was grown Klebsiella. So cephalosporin sulbactam was started at day 6 actually. So day 6, like the child was moved from an PH to the ward. In the ward, the child developed GTCS, a generalized tonic-clonic seizure in the morning. So it was he was given anti-epileptic drugs, and we sent all the routine electrolytes. Everything was normal, and creatinine was normal. BB was little bit in the higher side, so we thought it could be a press. And the tacrolimus level also was sent at the time, whether it's a TAC-induced press or TAC-induced encephalopathy like picture, but the level was also very low. And we also thought like, no, because the child has a lot of bleeding and like initially that PTABT was dearranged. So whether he had any intracellular hemorrhage or whether the child is basically a syndromic child, is a vaccinal child, whether he have a seizure prone. So we did an MRI brain. MRI brain came completely normal, and the child did not have a further seizure episode. So like, no, we are just continuing the routine steroid, MMF, and tacrolimus, and the child renal function stabilized. And but the only issue was like the child had a persistent drain output which was more than 500 ml per day. That was a huge for that 16 kg child. So we did a continuously renal Doppler and say this some collection was around the perinephric region, but it was stable. So we just continued the antibiotic, that's cephalosporin sulbactam. In the post-operative day 10, so actually, like, no, we were thinking to discharge a patient at POD 8 or 9, like, because he was doing fine. So he developed a new onset fever at the day of discharge, like what we thought initially to discharge the patient. The child had a fever and subsequently a fall in urine output, and the drain output was also increased to 700 ml per day. And creatinine jumped from like, no, within a single day from 0.6 to jump to 2.2. So we sent cultures, we thought of graft pyelonephritis, and antibiotics were escalated to meropenem from cephalosporin sulbactam. And we generally thought like, no, it could be any like, no, infection, whether that collection around the kidney was infected, or whether this was lymphocyl, or is having graft pyelonephritis, or the child was having a rejection. That was a DD initially we thought. So it happened around the night, like 11 p.m. Like, no, unfortunately, we didn't have a proper radiologist to do a renal Doppler or ultrasound at that time. So I told, like, no, because the child was thinking, like, no, better do a CT abdomen at night at 11 o'clock. And surprisingly, like, no, we found there was a renal vein thrombosis was there, and the kidney was very bulky. And, like, no, we found also the veg infarcts or the renal infarcts also was there. So in the same CT, we found there was some intra-abdominal collection also was there, but surgeon failed to observe. And the child became anuric the next day, and we started him on dialysis. And the child was continuously having a fever. I thought like, no, this renal infarct is causing all this DIC-like picture and having a fever. So we planned for a graft nephrectomy. So in the meanwhile, the night, like, no, I just started him on dalteparin, and continuously dialysis was given. Surprisingly, like, no, the patient urine output started improving and creatinine started declining. So, like, no, we initially we thought to remove the graft kidney, and we later changed our plan because the creatinine started declining and the child started improving urine output. So we thought, like, no, we just manage continuous as a conservative care, and we just salvage the graft kidney. But the only thing, like, no, the child had a continuous fever. So whether like no, I'm not sure like no what was the reason for this fever. So whether it because of this renal infection related fever, because infected tissue is releasing like DAC like picture and causing a fever. So we just continuously giving this dalteparin, and we are monitoring the Doppler daily basis, and we could be able to see the clearance of thrombus in the renal vein, and urine output was good throughout that time, and creatinine became normal. So we are not sure, like, no, whether this is causing this fever. And meanwhile, we have sent all the cultures at the time he got a fever. Nothing was growing in that one. And other thing was running in our mind, like, no, whether the child developed any peritonitis because he was on CAPD for 4 months before the transplant, whether he had any hidden collection in the abdomen. But the CT showed, like, no, kind of some perinephric collection around the transplant kidney was there, and some kind of a collection around the native kidney bed was there. But our surgeon, like, no, felt it could be a serous collection only, like, no, like that. He said, like, to wait and observe, like that. That was a plan given by the surgical team. The only thing in the good thing in the sepsis, like, no, the child had a stable hemodynamics and he had a stable graft function. So we sent all the repeat cultures. We again repeated the cultures and all the were sterile. So, but he continues to have a fever for 5 to 7 days, like, no. So the empirically antifungal also was started. And our pediatric ID physician was consultant. And they suggested to change meropenem to piperacillin, tazobactam, and teicoplanin to broadly cover the gram positive, gram negative, and other things. So that was added. And later, like, no, the reason of this fever was unveiled in a later stage. The drain culture grown bacterioids. So bacteria basically is a fastidious organism. It generally doesn't grow like no within a 3 to 4 days. It's basically like no, it's a slow growing organisms. So we thought like no, this bacteria could have been come from the or on the PD. In could be a PD kind of source of infection. So, and the meanwhile, that urine also like no grown a Klebsiella. So antibiotics like no escalated to as Avisepta aztreonum, and metronidazole was added for the bacterias because the child was having no continuously fever. So meanwhile, what I did like no, I just start the MMF because the child was having a fever. Means we were not sure like no whether we would continue giving an immunosuppressions. And so after this, the fever initially settled, and we just continued these antibiotics, Avisepta, aztreonum, and metronidazole. And anticoagulation was continued with serial monitoring of the renal transplant kidney Doppler, and it showed resolution of renal vein. So like no, we were happy like no, we'll just continue this one. So the child fever settled again in the post-operative day 17. Child again developed fever with fast tachypnea, and it was put on HFNO, and we found like no, there was a patch in the lung on the CT because that time like no, it is a December 2023 that month that was a flu season. There was a flu outbreak in even in hospital itself. The child was in ICU. There was like no a lot of flu patients were there, and we started him on antiviral also after sending the respiratory virus panel. At the end, it came as negative, and but the child was continuously having a fever, and just we managed conservatively with this antibiotic alone. And I planned to for a bronchoscopy and alveolage, but we didn't do that one because the parents they were not agreeing for that because like no once we start doing this bronchoscopy, child should be on ventilatory mode like no that the parent they didn't want to do that one. So just we managed conservatively and we sent a CMV that came negative. Meanwhile, like no, till the day kind of 3 to 4 weeks of transplantation, based on this pediatric infectious disease department inputs, we have given so much of an antibiotics for the child. We were given sulfasalazine, sulbactam, meropenem, and initially the child received ceftriaxone as a prophylaxis after transplant, and that was changed to piplosin tazobactam, and later, it was escalated to zavicefta and aztreonam, and gram-positive coverage also was given to this child, and metronidazole was added for bacterioids, and antifungal also was the child was getting antifungal also. So much of antibiotic the child has received, and with this amount of antibiotic, the child continuously having a fever spike. So even after stopping MMF, initially they had showed a declining in fever spike was there. So then we discussed in the department meeting. We thought better to stop all immunosuppression except steroid, and just we'll just leave the child with steroid alone. If and all the child was not improving, better to do a graft nephrectomy. But I was not in a sure whether to remove the kidney or not, because there was no renal vein thrombosis and creatinine was normal. The child was making some good urine output. So I initially I was not agreeing to for a graft nephrectomy, but all our department colleagues said better to remove the kidney because the child was having continuously fever. So I decided to better we'll repeat a CT abdomen with contrast and see what happens. So we repeated a CT abdomen and we found a organized collection. Initially it was not so organized because it's almost day 21, 22 post transplant. You can see an organized collection and the perinephric space along the transplant kidney site and also along the native kidney nephric bed. So we decided to tap that one. So we put a pigtail and initially full of prank pus came, we sent that culture. So in that time, because initially we sent a lot of cultures, nothing was growing except bacterioid. So we did a bactifast and fungifast that also was sent. This is a PCR analysis that we sent. And Zavicefta astronium was changed to tigecycline because the tigecycline is a better antibiotic to cover the intraperitoneal infections. So that was changed, and the metronidazole we have continued. But based on this bactifast result, only we found only no bacteria was growing on this bactifast and cultures. And so we just continued this tigecycline and metronidazole, and later fever spike settled. And after all this abscess collection were drained in the initial 24 hours, there was no further drain from the pigtail. So we thought we'll remove the pigtail. So the day before the pigtail removal, the child's urinary catheter was removed. We thought the fever was settled and the child was very stable. There was no drain from the pigtail catheter. There was no output from the pigtail catheter. So we'll remove the pigtail. So the surgeon said before removing the pigtail, I will remove the Foley's catheter first. So we removed the Foley's catheter first. The subsequent day, the child had more than 1 liter drain output, which smelled like a urine from the pigtail. So the child was passing significant urine even naturally also, via the natural orifice also, and creatinine was normal. It was 0.6. So the drain creatinine and the natural orifice urine creatinine was sent, which was around 22 milligram per dl. At the time, the serum creatinine was 0.65 milligram deciliter only at that time. So the child was it was clearly suggestive of a urinoma, urine leak. And the child was catheterized again. Before the catheterization, I did again a CT abdomen with contrast. And you can see there was a dent in the uretrovesical anastomosis. So the child was it was leaking. I don't know how we got this one. Maybe that it was a giveaway. Once we put the pigtail, so it gave away pressure that the uretrovesical anastomosis was was leaked from that time. At the same time, we found that we can reconstruct imaging. There was a kink in the renal vein. There was a focal narrowing which caused thrombosis actually. The initial picture did not show this one. So this could be the reason for the renal vein thrombosis. But anyway, we just continuing the dalteparin. So the 5th week of post-transplant, creatinine was 0.6 and maintained only on steroid and tacrolimus. Even tacrolimus level was very low. And so we just continued metronidazole and tigecycline, and the subcutaneous dalteparin was continued. And with this, the 5th week, we planned for the discharge. So all these days, his creatinine was normal, and it was an entire team work. This was the child at the 5th week of transplantation. The child was very happy in going home actually. The child discharged on the 6th week post-transplant. The story doesn't end actually. The child came 3 days after discharge in OP visits, again had a fever spike. So we clinically examined, there was no focus found. The child was very stable and we sent all the repeat cultures and we got an ID opinion also. They said like to give again 1 week of course of an antibiotic and just continue metronidazole. So already like we have given almost 4 weeks of metronidazole for this bacterial infection. So ID physician said like we'll totally give 2 months of a bacterial, two months of metronidazole course. Like we continued that one. After that, no further fever spike. And the child came last week and he was doing well. And there was no growth in the cultures. And repeat Doppler we have done. There was no renal vein thrombosis, but the kidney was bulky. So I reintroduced of 180 mg once daily. And steroid and tacrolimus, that low dose, whatever we were giving, we are continuing. And the dalteparin, which was given as subcutaneous, changed to a oral rivaroxaban now. So yesterday, the child came to OPD. So the creatinine was 0.68 and TAC level was 5.3. The Doppler we have done that didn't show any renal vein thrombosis, did not have any fever, and still the child is on continuous bladder drainage. So we are going to plan a cystogram next week, and then we'll plan further what to do for the urine leak and what to do for further that kink in the renal vein is there. What could be done for further? That is our plan actually. This is the child actually in home happily playing yesterday. That father sent me a WhatsApp video. So what could have been done better? I would like to answer. Means I don't have any answer actually. I can ask questions to you all actually. You can suggest me what could have been done better to avoid this post almost 5 weeks of post-transplant post. I had a lot of the child had everything in the thing. The child had urine leak. The child has peritoneal infection. Child had renal vein thrombosis. The child had seizure. And whatever you say, the complication the child had actually. And I
Thanks,
thank,
Saravana.
I don't want to speak more about the theory. I thank to the parents who supported me till the end of this treatment and the entire the pediatric team and especially the God Almighty who was along with me to save the child actually.
Well,
Okay.
any comments from the surgeons?
Yeah. Can I, sir? I'm audible?
Yeah.
Yes, Marianandam. Yes, Marianandam.
Hello?
Yeah.
Yes,
Yeah.
Marianandam, please.
Right, sir. Yeah. Yeah,
Saravana,
you said when it rains,
can
it
unshare
pours.
the slides. Saravana, you can unshare. Now you can.
What you do? Yeah. Yeah, Saravana started with when it rains, it pours. But actually, yeah, it was like flood we had the recently in Chennai. It was a flood and the misfortune. Actually, three things which I see in this particular case was the patient was the inadequate preparation. Because when she was on CAPD, reflux nephropathy causing the CKD, generally they are on the higher grade. They got four, the minor grade we can ignore. And doing at that time of cadaver transplant also is not a good idea. These are my views. And unfortunately, the same patient had some collection around the kidney. Then he had a renal vein thrombosis, probably due to the kink. And later on, he has got a urine leak. These are the surgical issues only. Of course, he also had a medical issue. So the preparation regarding once you IV normally infective kidney, we don't do the nephrectomy along with that. Even if I would have been the surgeon, we will call the nephrologist on board. And if we find a frank turbid urine, we won't go ahead with the transplant. It is annoying. I think strongly feel this is the one mistake we started with, and that might have contributed in partly to the subsequent this thing. He started oozing everywhere, then he continuous fever, abscess everywhere, then also had urine leak. That's the one thing. Renal vein thrombosis, actually in this particular case, from the adult, generally they have a longer vein in the cadaver. Usually this looks a little longer. You should not have, artery can be long because the flow is under high pressure, thrombosis is rare, but the venous blood is slow because even a small kink can cause thrombosis. Fortunately, we would have opened at the same time because you said it's a bulky kidney and renal vein thrombosis. We should have gone ahead with the nephrectomy. But I don't know, in the retrospect, you could save the kidney. We would have gone ahead with the nephrectomy within hours for that case. Coming to the urine leak part. So he had, after stent removal, he would have had this partial this thing of the anastomosis. The ureter also looks little longer than what normally it should be. And after putting in the catheter, it settles down without any percutaneous or intervention or a stenting. And I am sure this patient has to be followed up for developing ureteric stricture in the future. Even now, it may be partially draining. So these are the thoughts in my mind. How to prevent this? The reflux kidney, suspecting infection, bilateral pre-transplant nephrectomy when the child comes top in the waiting list itself. That's what generally we do. If it is not infected, one side kidney will remove before, so that we'll know any infection, any pathology we'll see. Then the next kidney we'll do along with the cadaver. We have done for some cases, but in generally we avoid bilateral nephrectomy along with the transplant. Even though the reports are there, you can do. But in this patient, I think particularly once we open, the surgeon nicked the pelvis and some turbulent urine, and I was not happy saying that. And the surgeon did. Normally, the nephrologist is the one who's through the patient. We normally work as a team. He should be on the board. You are having right to tell, oh, better not to go ahead with the transplant. We are seeing a frank focus. That could be in the kidney, or another one focus was in the CAPD. I have seen many times. Even after transplant, they had a abscess in the interperitoneal interbowel collections. So these are my thoughts, sir. Thank you.
Saravanan, I have two comments. One is that, the kink in the vein persists. So I think, how long are you going to keep him on heparin? You can't keep the child indefinitely on heparin and prevent. So is anything going to be done to...
Heparin, last week it changed to rivaroxaban, oral Xarelto tablets. It was changed actually.
No.
I changed.
How long are you keeping the child anticoagulant? Because as long as the venous kinking is there, it's likely to thrombose again, isn't it?
Yes, sir.
The
But I'll get opinion from you, sir. I don't know what to do further actually. Even our team also very behind actually.
Talk to your surgeons and see whether they need to go back in and shorten the vein by, say, I don't know. Second thing is about...
it's not easy, sir. It's not easy. It's not to go. We'll end up in graft nephrectomy.
Second thing is about MMF. See, MMF will make the child more prone to UTI. So I would actually switch to azathioprine, because at least the risk of, this graft function-wise is fine. So I think you are probably safe to switch it from MMF to this thing. And also, do you have the child on Septran prophylaxis? Because that...
Yes, sir. Yes, sir. He's on all Septran, CMV, and fungal prophylaxis. Everything
things are
the child is on. Yes.
That's about it, I think. Okay. Well, anything?
Yeah, nothing, sir. I just watching how the Muruganandam narrated. I think I got one clue from Muruganandam's suggestion that Saravana, you have to watch for the ureteric stricture. He rightly pointed out, even the baby comes out well with in terms of good function and things. You said when the surgeon came out, they left open the wound, and when it was closed again.
It was closed on the third day, sir. Actually, third post-operative day.
Oh yes, fine, okay.
When there was no oozing, that time it was closed. Even even also I was not very happy to do an nephrectomy, but unfortunately it was not communicated with me at that time.
Yeah.
Oh, that is wrong. That is wrong. Yeah.
Okay.
He should be involved. The nephrologist, because he's the one who sees the patient and counsels. He has to be on the board even in every surgical decision.
Even we are very good friends actually, but that was not there was miscommunication actually.
Yeah, it happened. That's good.
The child basically underwent all kind of bladder assessment before transplant.
I think it was a very good persistence, and after that you have put your hand into that by doing a transplant nephrectomy. After that you have managed very well, your perseverance, and you did not leave that. So that's a good thing I can sense from the teamwork. Okay.
Okay.
So we didn't have a sleep like for the last
Saravanan?
almost 6 weeks actually.
Saravanan,
Okay.
Yes, sir.
Saravanan, one question.
Ah.
Sorry, sir. Sorry to interrupt.
No, Raj, if you are all right to do, please.
Yeah, have you assessed the bladder pre-transplant in this patient?
Yeah, it
Do
was
we have-
assessed actually. It was completely assessed by a pediatric urologist, but he was not a part of this transplant team. Like, no, he said like it was normal, so he just go ahead. But like this happened. That's all. Like, no, we can't blame like no one.
Yeah, all these things looks like it's not a lower tract problem. They're all happened with the upper tract, above the ureter orifice. So bladder must be normal. It's not a secondary reflex.
Thanks, Zach. Because Muruganathan sir, actually the thing is, it's like an
Yes, sir.
it's like an amputation. If you know you do amputation before, that's the last measure. Nephrologists won't do kind of just like that, because we live with the patient all the time. We know the
I know.
So I think what Saravanan did is tough job, but he just ultimately came
Everyone
out.
was suggesting, sir, like to go for nephrectomy. Like, no, it's easy to do a nephrectomy, but like, no, it was a very tough decision. Like, no,
Yeah.
discuss with the parents.
Absolutely, I agree with you. Absolutely agree. It's not a very easy decision, and we have spent a lot of money, time, mind, to everything. So I think it's a very
No, actually, if the graft renal vein thrombus with the bulky kidney, it can rupture and we will lose the patient in hours. So that's the one thing we know. Luckily, it did not happen. By somehow you have anything. You are lucky.
actually he showed a static image. It's not a complete occlusion of the entire renal vein. Probably it's a partial occlusion, and probably we have gone for a CT angio with the venous phase. That would have given the caliber of the vessel. I think one suggestion next time, because I think he got in the late hours of 11 o'clock at night, and probably not catch anyone. That's the only test available for him. Anyhow, that's the reason he responded so quickly to LMWH. So
you must be partial. Correct. You are correct.
Okay. So
maybe timely pickup also, sir. Could be.
Thanks, Saravanan. And I think you patiently, I think we have exceeded time, but still we enjoyed your presentation. Both cases, both of you given a lot of insights. I always tell that destination is not important. The journey, how you learned. I mean, how some decision from the back we can make comments, but case as close proximity to the patient, it makes a real difference. And we have learned a lot from you, both of you. I thank Chako sir and Muruganathan for especially Muruganathan for it. I think this is the first time we roped in urologists to understand Dr. Muruganathan and for your
Thank you a lot. Thanks a lot.
And thank MCure people. They've been consistently helping us to conduct this program. And once again, thank all the participants who are the real encouraging people. They are almost 80 to 90 attendants, and our aim is to benefit everyone through the suffering from few nephrologists who've gone through. It may be a lesson, and they can take some hue from this presentation. They can put into clinical practice. Thanks, Chako sir, especially for you. Thanks, everyone. And
thank you.
We'll wait next. Thank you.
Thanks a lot, sir. Good job. Thank you.
Arun, are you there? Thanks.
Thank you, sir. Thank you. Good night.
Thank you, sir.
Raj,
thank
bye.
you. Thank you, sir. Well, sir. Raj, sir. Chako, sir.
Thank you. Thanks a lot.
Thank you.
Thank you.
Thank you.
Thank you, sir. Good night.